What is important for the patient is to get the right treatment and get it as soon as possible.
For many years, we used the EKG only because we focused on patients with the large infarctions.
The ECG is not ideal. It has blind spots. A biomarker may benefit patients with acute myocardial infarction.
Troponin has changed a lot, a new way of thinking also.
Patients with myocardial infarction, we know that 40% have ST elevation in the EKG, and these patients are easily diagnosed based on symptoms and EKG. But 60% of patients have no classical ST elevation. These patients, called non-STEMI, actually have a much higher mortality compared to patients with STEMI.
The applicability of the troponins is broadly and could help clinicians, not only cardiologists, but also other clinicians to go for the right diagnosis. We are used to use troponin when patients arrive at the hospital, but sometimes we are a little bit late. Why not try to measure even before a patient arrives?
We find that the treatment of the patient starts when the patient dials 112.
We have a very well-developed pre-hospital diagnosis, not only by ECG, but also by biochemical markers like troponin, so that we can triage the patient to the correct department right from the beginning.
So this means if we do the biomarker analysis in the ambulance, then we should be able to diagnose around 50% of patients with myocardial infarction based on the biomarker analysis alone.
Troponin, anyway, is the preferred biomarker.
All patients with some chest discomfort or chest pain will benefit to have measurements.
Rapid admission of patients with acute chest pain actually improves mortality in those patients. So this is a very important finding, that you save life.